So we're going to start off with a little quiz, and I want you to look at those pictures and just in your mind, we'll come back to it at the end of the talk, decide which one you think is the skin cancer. Okay. So the goals of this talk are to learn about the three most common types of skin cancers, being basal cell carcinoma, squamous cell carcinoma, and melanoma. And we're going to talk about what they look like, risk factors, and we're then going to talk about how skin cancer is diagnosed, and then how they're treated, and then lastly, we'll talk about the prevention of skin cancer. So first I'm going to talk about basal cell carcinoma, which is the most common type of skin cancer. We estimate 1 to 2 million cases of basal cell carcinoma a year in the United States, and this represents about 80% of all skin cancers diagnosed each year in this country. This is one of a group of what we call non-melanoma skin cancers, so these are not melanomas, and this type of skin cancer is very rarely fatal. So typically we see these in sun-exposed areas like the head, neck, trunk, and extremities. They can be described as pearly or waxy. People will mention that when they wash their face, a spot bleeds very easily with minimal trauma. And these are some examples. Oh, I should mention, for those of you eating, there will be pictures in here, and sometimes people are okay with that, and sometimes people aren't. So if you're not, I guess save your lunch till the end. So these are examples of basal cell carcinomas. They're generally pink and pearly looking, and sometimes you just see kind of a bloody spot or just what looks like a scab that someone says will not go away, has been there for some time. So the next skin cancer I'm going to talk about is squamous cell carcinoma, and that's the second most common type of skin cancer. Around 200 to 400,000 cases a year in the United States. And this represents about 16% of all of the skin cancers diagnosed. This is with basal cell carcinoma make up the group of non-melanoma skin cancers, so these are not melanomas. And like basal cells, these are rarely fatal, although these are a little more risky than basal cells. So squamous cell carcinomas we typically see in the same areas like we saw for basal cells, the sun-exposed areas, or you can see them in scars or long-standing wounds, and they're more warty looking. They're kind of rough and pink and scaly. So here's some examples of some squamous cell carcinomas. So the third most common type of skin cancer is melanoma, and this, even though it's the third most common, it accounts for the majority of skin cancer deaths. The estimate for 2014 is 76,100 melanomas will be diagnosed. There will be over 9,700 deaths from melanoma in 2014. And the risk of getting a melanoma depends on the color of our skin. So about 2% of white patients, so 1 in 50, will get a melanoma over their lifetime, compared to about 0.1% in darker skin patients. So black patients have about a 1 in 1,000 chance of developing a melanoma of their lifetime. It's not 0, so it's lower, but you still have a risk. And Hispanic patients are in the middle. It's about 1 in 200. So when we talk about what melanomas look like, we discuss the A, B, C, D, E's. A being asymmetry. So if you look at the top pair of pictures, the one on the left is asymmetrical. It's asymmetrical in terms of pigment, and if you were to draw a line anywhere through there, one half would not match the other as compared to the image on the top right, where no matter where you draw a line, one side looks like the other. We talk about B for borders being irregular, so if you look on the second pair down, the one on the left kind of looks like a cloud, has that irregular border, whereas the one on the right is very round. Colors is C, and we're talking about multiple colors. So the third pair down, you'll see on the left there's some brown, black, pink, compared to the picture on the right, which is uniformly brown. And D is for diameter, so it's bigger than the head of an eraser, or 6 millimeters. That doesn't mean all melanomas are big like that, but it is a clue that it may be. And then E is for evolution. I do not have a pair of pictures for that because that is changed. So over time, if a lesion is changing, that can be concerning. So in terms of location, the most common location for men to have melanomas are the back and the head, whereas women, it's the leg. And then for people of color, it's typically on the hands and feet and the nails. So here are some pictures of melanomas. And that's a nail melanoma, so we're looking for dark streaks on your nails. So now everybody's looking at their nails. But some people have bands on their nails, and if it's on all your nails, that's normal for you. But if you have one that looks different, is darker or wider, then that can be a clue that something is wrong. If you can see in the top picture on the left, that doesn't really look brown, it looks pink. And it's hard to see on that screen, but in kind of at 11 o'clock on that lesion, there's a little bit of brown. So sometimes melanomas are amelanotic, which means they are not brown or black, they're pink. So that can be confusing. And then there's some other examples that meet the A, B, C, D, E's. So now I'm going to talk about risk factors for skin cancers, and I'm going to start with the non-melanoma group. So that's the basal cell and squamous cell carcinoma. So the risk factors are UV radiation from the sun or from indoor tanning, having light skin and light eyes. The older you get, the more likely you are to develop this type of skin cancer. Men are more likely to develop it than women. Once you've had a history of skin cancer, you're at increased risk of having another. If you've had radiation treatment for cancer, you're at increased risk in the area that was exposed to that form of radiation. People who have had chemical exposures to arsenic and coal or tar are at increased risk. People who have solid organ transplants like kidney, heart, liver, who are on immunosuppression, they're at increased risk for getting skin cancers, and it's usually most commonly squamous cell carcinomas, but all of the skin cancers are elevated in this group. The wart virus, human papillomavirus, is associated with skin cancer, and smoking for squamous cell carcinomas on the lips. So the risk factors for melanoma are different than the risk factors for non-melanoma skin cancers. Some are the same, like the first one, UV radiation. The difference here is with the non-melanoma skin cancers, it's just chronic cumulative sun exposure, whereas for melanoma, it's intermittent sun exposure, so a history of a sunburn puts you at increased risk for melanoma, whereas a history of a sunburn does not put you at increased risk of non-melanoma skin cancer. Tanning bed use is for both groups. People who have more moles are more likely to develop a melanoma. People who have dysplastic moles, so that's atypical moles, they look a little bit funny, they're at increased risk. People who have light skin, red hair, people who are older are more likely to develop melanomas. Men are more likely to develop melanoma than women. If you have a family history, so a first-degree relative who's had a melanoma, you're at increased risk. And if you've had a melanoma once, then you're more likely to have one again. And again, immunosuppression, so solid organ transplant patients have a higher likelihood of developing a melanoma than people who have not had a solid organ transplant. So if you have a spot that you're concerned about, what should you do? You should call your doctor, your primary care doctor, or if you have a dermatologist, you can call them, and then they'll evaluate it. And if they think it's concerning for a skin cancer, then they'll recommend a biopsy. And there's lots of different kinds of biopsies that can be done depending on the lesion. Sometimes we take part of it, sometimes we'll take all of it in the biopsy. Sometimes we have to put stitches with the biopsy, sometimes we don't. All biopsies require anesthetizing the area, so that means it's going to be numbed up with a stick and a needle. And then that specimen gets sent off to the pathology lab where it's looked at under a microscope. So if they call back and they say you have a skin cancer, then the treatment depends on what kind it is. So I'm first going to talk about the non-melanoma skin cancer, so basal cells and squamous cells. And you can see how long the list is. There's lots of different options. So we're going to go through each one. Okay, the first one is surgical excision. So what happens in this case is the biopsy site plus any remaining lesion plus a rim of normal appearing tissue is removed. It's cut out. And then stitches are used typically to close the wound, although not always. And if stitches are used, you're left with a linear, so a line scar. It eventually turns white. That tissue that was removed gets sent back to the lab and it's evaluated to make sure that the margins are clear. Another treatment for the basal cells and squamous cells is something called electrodesiccation and curettage, or a scrape and burn. So the area is numbed up, but instead of cutting it out and putting stitches, the skin cancer is scraped out with a special blade called a curette, and then the base is burned. And we do this a few times in a row, and then we let it heal. And instead of being left with a line scar, you kind of get a round, white scar about the same size that the skin cancer was. It takes longer for it to heal without stitches, but it's a less invasive procedure. People who have pacemakers and defibrillators, it depends on the location of the skin cancer whether or not this is an option for you, because the electrodesiccation, the burning part, can interfere sometimes with pacemakers and defibrillators. There's something called Mohs surgery, which is a Mohs surgeon is a specially trained dermatologic surgeon. And what they do is they can cut out the skin cancer with smaller margins because they can examine the tissue in their office while the patient is waiting, as opposed to sending it off to the pathology lab and getting a report a few days later. If there's cancer extending to the margin, then the Mohs surgeon can go back and remove more tissue just in the area where there's remaining cancer. And then the defect is either left to heal on its own, or there are stitches or repairs are used to close the wound. So the indications for Mohs surgery are certain locations where we're known to have a high risk for recurrence. So the creases around the nose, ears, skin cancers that have come back after a previous treatment with either excision or Mohs or electrodesiccation and curettage. Certain types of skin cancers are more aggressive, and we'll send them to Mohs initially. Or skin cancers where it's hard to tell where it begins and ends, because if we're sitting in our office and we can't tell where the skin cancer ends, then it's hard to cut it out with a margin of clear skin around it. So the benefit to Mohs surgery is it's 100% of the margin is evaluated, which is different than standard pathology where the specimen is kind of sliced like a loaf of bread and a few of those slices are evaluated. And there's minimal tissue removal. But the kind of downside to Mohs surgery is it takes a lot more time, so it's usually a half a day at least procedure, and it's much more costly. So then there's a bunch of other treatments for skin cancers, basal cells and squamous cells, and they include radiation. So patients who have large tumors that are not good candidates for surgery, we sometimes recommend for radiation. Cryosurgery is freezing with liquid nitrogen. Usually we'll use that in combination with the scraping and then freeze. This is different than when you go and you get the little freeze at the dermatologist for all the little things. They're not treating skin cancers like that. They're treating pre-cancers. Immunotherapy, so these are topical creams like imiquimod, Aldera, Zyclara, that you apply to the skin, and it induces an immune response. So it calls your body's immune system to the area in hopes that your immune system will clear the skin cancer that's there. And one advantage to this is there's little to no scarring. We don't have a lot of long-term data. I mean, these things have been around for maybe 10 years or so. So besides the topical immunotherapy, we also have topical chemotherapy. So 5-fluorouracil, it comes in cream and solution, also known as Effudex or Carac or Fluoroplex. And these are used to treat superficial skin cancers, so superficial basal cells or very early squamous cell carcinoma in situ. And again, these are for areas that are difficult to treat surgically or the patient won't tolerate it. And lastly, there's something called photodynamic therapy. That's when a chemical is applied to the skin and then a light is then shown on that area. It can be blue light or red light depending on what kind of chemical was applied. And we don't have a lot of long-term data on this either. So Recently, in 2012, a oral medication was approved for basal cell carcinoma. It's called vismodegib or Araveg, and it's approved for metastatic basal cell carcinoma, which is extraordinarily rare. These are people who have genetic, we call it genodermatoses. They have genetic problems where they have thousands of basal cells starting at a very young age. Or for patients that cannot have surgery and the cancer is not superficial to use these superficial treatments for. It's a pill that you take daily. There were no complete responses in the metastatic basal cell patients, and about 20% of the patients with locally advanced basal cell had a complete response. So it's not great, but it's something. And everyone always asks about, isn't there a laser you can shine on it to make it go away? Not yet, but the photodynamic therapy is pretty close. And that's where the chemicals applied and then the special light is shown on that area. So melanoma is very different. Melanoma is predominantly a surgical disease, so you need to cut out the melanoma with larger margins than we use for basal cells or squamous cells. And then depending on the depth of the melanoma, then some patients are recommended for sentinel lymph node biopsy. And they use that a lot also in breast cancer, but that's where some dye is injected around the area of the melanoma, and then they track to see which lymph node that dye moves to, and then they will remove that lymph node to evaluate it under the microscope to see if any melanoma has spread there. And that kind of affects the stage of the melanoma. That sentinel lymph node biopsy is recommended for stage 1B and up. It is not recommended for stage 1A or in situ melanomas. So if you have advanced melanoma, so that's melanoma that has spread either to the lymph nodes or to other organs, we have a few options. One is immunotherapy. So that's where we give you something systemically to try to wake up your immune system, and then it can hopefully notice the skin cancer and clear it wherever it is. Chemotherapy is not very effective, so we don't use much of the standard chemotherapy. Radiation is mainly palliative, so if you had some metastatic lesions to the brain, they may use radiation to shrink them so that you're able to move better or feel better, but it's not curative. And then limb perfusion, so if you were to have a melanoma on an extremity, like an arm or a leg, that had spread locally kind of in that area, sometimes they'll kind of put a tourniquet around the arm, let's say, and then put very high doses of chemotherapy in there, much higher than you could tolerate throughout your whole body, and try to kill the cancer that way. There were 2 drugs that were approved in the last few years for metastatic melanoma. One is called ipilimumab or Yervoy, and that was approved in 2011 for metastatic or unresectable melanoma, so that's melanoma that can't be cut out. And patients who were on that had a survival of 10 months versus 6.5 months. So based on these numbers, you're getting a sense of metastatic melanoma is not a good disease to have. And a 1-year survival of 45% versus 25%. And then the vemurafenib or Zelboraf, that's for certain melanomas that have a BRAF mutation. That's a test they do on the tissue after it's been excised. And that survival was about double, so 16 months versus 8 months for patients who were not on it. So people ask about precancers. So there's nothing that is a precancer for a melanoma. There are dysplastic or atypical nevi, and people who have those are at increased risk of developing a melanoma, but it's not like a colon polyp that they remove and they know that that polyp would have turned into one eventually. This is just a marker that you're at increased risk, but it doesn't mean that that mole, if it sat on you for 100 years, would have turned into anything, which is kind of confusing to think about. And then the other thing that sometimes people get confused about is melanoma in situ. That is a thin melanoma that has not invaded yet. So that actually is a cancer. It's not a precancer. Melanoma in situ is a cancer. Atypical moles are just markers for risk, but are not precancerous. There is no precancerous state for a basal cell carcinoma. But there is a precancer for squamous cell carcinoma, and that's actinic keratoses. So those are the things we freeze when you come to the office, or sometimes we have other treatments for. And they have about at most 5% chance of turning into a squamous cell carcinoma. They're kind of the rough little gritty things that you may feel on your face or arms. And some of them will go away on their own, and some of them will just sit there as an actinic keratosis for the rest of your life, and a few of them will turn into squamous cell carcinoma. The different ways of treating them: we freeze them, we can do the light and the chemical, there are topical creams, Effudex, 5-FU, Aldera, and imiquimod, Zyclara, Picato, lots of different options to try to prevent those from turning into skin cancers. So now I'm going to shift to prevention. And let's see, and it's, can everybody see it now? Okay, so I kind of put up the risk factors again, and I know some of them are too small to read, but I bolded the ones that are modifiable, because we can't change whether we're a man or a woman. We can't change our family history. We can't change our age, but we can change a few of these things. So we can change our radiation exposure, either from the sun or indoor tanning. We can change our chemical exposures. We can change our risk of getting human papillomavirus, and we can change whether or not we smoke. So sun protection, the easiest thing is to try to avoid peak hours. So we're talking 10 a.m. to 3 p.m., just not being out there then, which sometimes can be easy and sometimes it cannot be so easy. For me, when we go to the beach, I have 3 young kids, so it's easy. We're up early, we're out there early, we come in for lunch and a nap, and then we're out in the late afternoon, and that works for us, but I don't know how it's going to play out as my kids get older and napping phases out. Sun protective clothing, so hats with a brim, are much better than hats like baseball caps, because that leaves your ears and your neck exposed. So you want a big hat. You can look for clothing that has what's called UPF, or ultraviolet protection factor. You'll see a tag on a lot of sporting goods stores, their clothing there, or even Target, Walmart in the right season will carry these items that protect you from the sun. And you're looking for a UPF factor of 50 or greater, which is excellent. And these fabrics, usually it's the weave of the fabric that protects you against the sun. It's not a chemical or anything that's on the fabric. And then sunscreen. So the FDA passed guidelines a few years ago, and they finally went into effect last year, and all sunscreens are now required to say broad spectrum if they block UVA and UVB. If it doesn't say broad spectrum, then don't get it, because it's not blocking the rays that you need to block to prevent skin cancer. They also have to indicate SPF, so sun protection factor. They have to say whether or not they're water resistant. They can either be water resistant 40 minutes or 80 minutes. You will no longer see waterproof on a sunscreen, because there's no sunscreen that is waterproof. You will no longer see sweatproof, because there's no sunscreen that is absolutely sweatproof. And you will no longer see sun block, because none of these things block the sun completely. And it was considered false advertising. So this is directly from the FDA, kind of an example of what a bottle may look like and what you're looking for, but you can see it says the brand, but then underneath it, it says broad spectrum, so that you want to see UVA and UVB, and it says SPF 15. We usually recommend SPF 30 or greater, and then you can see the water resistant down at the bottom. So when you go to the drugstore and you're looking at all the sunscreens, you want to see broad spectrum, you want to see SPF 30 or greater, and if you're somebody who's going to be near a pool, a lake, then you want to look for water resistant 40 or 80 minutes. The other way to do it is you can flip the bottle over and you want to look at active ingredients, which you don't really need to do anymore now that the FDA has said that they have to indicate their broad spectrum. But those are the ingredients or combinations that you need to see to know that you have both protection against UVA and UVB. The SPF number only tells you UVB protection, because that SPF number is related to how quickly you'll burn using these products, whereas UVA does not cause burning, but it does cause skin cancers, and it also is the main factor in aging of the skin, so wrinkles, sagging, and discoloration. So how much is enough? So we don't put enough on. So when they do these tests to indicate their ratings, they use a certain density, which is 2 grams per centimeter squared for each application, which turns out to be about 30 milliliters for the average size adult. For those of us who don't know exactly how much 30 milliliters are, that's like a shot glass completely full of sunscreen for each application for an adult-sized body, and we don't do that. That would mean you're going through your 8-ounce bottle of sunscreen in 8 applications, and most people have their bottle of sunscreen around for an entire season plus. So we don't put enough on. It's hard to put that much on. So one recommendation is to try to put it on in layers. So put some on and then wait 10 minutes and put some on all over again. The other thing is you want to apply 15 minutes before you are going to be exposed, and you need to reapply every 2 to 3 hours if you're going to be out there. So indoor tanning, avoid it. If you have friends or children or grandchildren who do it, tell them to stop. We now estimate 420,000 cases of skin cancer a year are caused from indoor tanning. And of those, 6,200 are melanomas. That's the kind that can kill you. There are more skin cancers in this country caused by indoor tanning than lung cancer cases caused by smoking. And so I ask my patients all the time who tan, and I always say, well, do you smoke? And they all look at me like I'm crazy. Like, why would they do that? But they're engaging in a risky behavior too. Just like smoking and lung cancer, with indoor tanning and skin cancer, there is a delay. So you don't get the cancer like right when you go in the tanning bed. So sometimes it's hard to look that far in advance and modify your behaviors. But it's really bad. And I should also say there is coming up in the North Carolina Senate trying to ban 18, and you can't use a tanning bed until you're 18. So if you're at all politically involved and you want to write a letter or call your local representative, you should do that. So the other is HPV, human papillomavirus. That's the wart virus. There are lots of different strains of wart virus. Some of them go on the hands, some of them go on the feet, some of them go on the genitals. Gardasil is a vaccine that was designed to prevent cervical cancer, but the same HPV viruses that cause cervical cancer cause squamous cell carcinomas in the vulvar area, or penile squamous cell carcinoma. So it can, we think it's going to prevent against that as well. And then if you're avoiding smoking, to prevent squamous cell carcinoma of the lips. Okay. Yep. So now we're back to our quiz. So we can look and see which one do you think is a skin cancer, the left or the right? Okay, yeah. So that is. So that's a melanoma. You can see it meets the ABCs. It's asymmetric. It has irregular borders. It's multiple colored. We can't say whether or not it's as big as a pencil eraser because I didn't put a marker up there. But that's right. The one on the right is just a benign nevus, so a mole. This is a hard one. No one wants to say anything. Okay, I see someone pointing to the left. Yes, that's a basal cell carcinoma. So that's that pearly one. The one on the right is called a seborrheic keratoses, and that's probably what most people come into my office for. And they say, what is this thing? And people get them all over their back, under the breast. Those are inherited. A safe bet is if you have lots of them that look like that, then that usually means it's not a skin cancer. But often people come in for that, and we diagnose other skin cancers. So if you're concerned about something, come in. And this one, the picture's a little hard to see on the left. But I think so. I hear some people saying right. Yeah, so that's a squamous cell carcinoma. That's the warty one, the kind of pink, rough, scaly. And so the take-home points are basal cell and squamous cell carcinomas are common. They should be treated, but these are not things that typically will affect how long you live. Melanoma is very serious. And that can affect how long you live. And we think about the A, B, C, D, E's for identifying melanomas. Indoor tanning is bad, and nobody should do it. If you have a concerning lesion, get it looked at by your primary care doctor or by your dermatologist. And there are multiple treatments for the non-melanoma skin cancers, whereas melanoma is predominantly a surgically treated disease. Actinic keratoses are precancers for squamous cells. There's no precancer for basal cell or melanoma. And sun protection prevents skin cancer. They recently did a study in Australia where they kind of randomize people to whatever they normally do versus kind of given sunscreen and harassed about using it all the time. And over, I think it was only 2 years, they had a difference in the number of skin cancers diagnosed. And in Australia, they're having a big problem with skin cancer. So it works.